everybody. I think we'll get started in the interest of time. You can find a seat. Sorry, I've got to project my voice and not my germs. Welcome everybody to the noon meeting today. For those who don't know me, I'm Tammy Phillips. I'm the chair of the school DRC, and the DRC is hosting the noon meeting today, which is very exciting, and we're very excited to have Lyn Horn with us. Lyn is director of the UCT Office of Research Integrity. I've attended some of your trainings, and she's really an expert in all areas around research integrity. For a little bit more of a formal bio, Lyn is a medical doctor with a PhD in bioethics, has worked as a clinician in the public health sector for over 20 years, also worked in the field of research ethics for a very long time and research integrity since 2011. And in her current role, she's responsible for the institutional-wide promotion of responsible research practice, including RCR, education and training. And she was co-chair of the World Congress on Research Integrity in 2022, which took place here in Cape Town, where the Cape Town Statement was generated. And you should look that up if you haven't already come across it. And so Lyn is going to chat to us about data sharing and reuse. I think we'll talk sort of 25 minutes or so. And if you have questions, I think Lyn's happy to also take questions as you go. And otherwise, we can have some discussion. I will try to keep an eye. I don't think I can see, but Carmen, you can see if there are comments coming up in the chat as well, which we'll circle back to for colleagues online.
Okay, great.
Thanks very much,
Okay,
Lyn.
thanks so much. Thank you, everyone. Thank you so much for having me. So I'm going to talk. I really don't mind if you interrupt me as we go. I need to tell everybody that I am significantly hearing impaired, so sometimes I might not be able to understand exactly what you say, and I might walk up to you, but that is, and ask you to repeat it, but that's the way it is. So I'm going to talk just 3 slides very briefly on the basic ethics principles that we all know, and then looking at secondary data use. So you using research data from others or data collected for purposes other than research. Then I'm going to talk about the legal aspects, and that part of my presentation is a bit dense, I'm afraid, and maybe a bit boring, but it's kind of the core, if you like, of where all the issues. So I'm hoping that once we've gone through that, we would have actually provided some of the answers to some of the questions. And then I'm going to circle back to data sharing, where you are sharing your data with collaborators or making data open, and then just ending off. Okay, I hope that is going to work for you. So just a reminder that there are basic ethics principles. We all know the ones on the left, the 4 principles of bioethics, and then the ones on the right have become entrenched, I think, in research ethics. And then currently built into the National Health Research Ethics Guidelines, so the benchmarks of research ethics, which I'm not going to go through in any detail. This is an old slide, but I think it's an important one to just reflect on. And that's the idea, particularly when we're thinking about how we use data, is the idea that traditionally research ethics, especially as it was first published in the Belmont report, is very much, it's quite rights-based. If you know anything about philosophy, it's deontological principles, so it's quite rules-based. It's based on the primacy of autonomy and protecting individual people from avoiding exploitation of individuals, particularly in a research context, also avoiding exploitation of communities. And it's really quite a protectionist approach, especially when we are worried about vulnerable groups or particular, especially vulnerable groups like children. So that's a very traditional research ethics approach. And if you've ever sat on a research ethics committee, that's how a research ethics committee operates. Public health ethics on the other side has maybe some more slightly different values. It can sometimes be a little bit utilitarian, so very outcomes focused. It's focusing a lot on the promotion of the common good. There can sometimes be a communitarian ethic, with importance placed on involving communities and relevant publics in decision making, and values of solidarity, reciprocity, stewardship, fair benefit, and sometimes maybe even less emphasis on individual autonomy in some contexts. So there's there can be a kind of a tension between these two sets of principles. Not always, but and I think it's ethics committees who review research and research involving secondary or data use have to balance the principles of traditional research ethics and protection and the public interest. And the privacy legislation, particularly POPIA, very much has that coming through it, where it's focused on protecting individuals, but there is also exceptions made if there is a strong public interest. So that's just a brief talking about basic ethics principles. And now I'm going to talk about use of secondary data. So it's basically you using data that's been shared with you or collected or produced elsewhere. So, yeah, we often have debates around this, especially at a broader university level, as to whether even use of secondary data sets requires ethics approval. I think particularly health data sets, in my view, definitely does. And I think there are three broad sets of ethical considerations with secondary data use. And this is why you do need to submit proposals to the HREC for approval. And so the first set of considerations is around the provenance of the data. So where did the data come from? Who owns it? Was there permission to use it? What was the scope of the original consent? What if there was no consent? Can we use the data? And then the second set of considerations is around privacy and security. So has the data been anonymized? Is it identifiable? Do I need it to be identifiable? Is there an access code to that I have access to identity? Who holds that code? All of these become very important questions in the context of the current legislation. So privacy and security is our next sort of group of concerns. And then the third one is what are we going to do with the secondary analysis? And does it have the possibility to produce information that could be stigmatizing or harmful to communities or groups, even if not necessarily harmful to individuals? Can data be used for commercial purposes that may be contrary to original consent agreements and may be problematic from a fair benefit perspective? And I think this is particularly relevant for genetic research, and certainly historically there have been cases and issues around how research collected for one purpose, genetic research, has then been used for various other things, and sometimes commercialization as well. So if we just have a look at provenance, where does your data come from? So it could be research data from a research project that you were involved with from the beginning, and that probably throws up less ethical issues because you would have been part of, the research proposal and writing the informed consent form and all of that. It could be research data that's been collected by others and that's been shared with you under a data sharing agreement or via data access committee. It could be data in an ethically approved and registered data research looks like I've got some typos in there, but in a research repository, which has been collected with informed consent and future use consent. It could be clinical data, and I think that's where it can often be quite tricky. So can we really access clinical data that where there was no research consent for use in research? And clinical data obviously can be extremely valuable. And then public health data that belongs to government departments or organizations, TB clinic data, preventional health monitoring data. I'm sure you would have all kinds of, data sets that you would want to be able to have access to. Then the second group is around privacy, confidentiality, and security, and around whether or not data is identifiable, whether you or not you receive the data as identifiable data, whether it's coded. So these are all some of the questions, and as I get to the legislation section, I think you'll see why these questions are really important to consider. And then obviously the third group is what are we going to do with the secondary data, and what kind of new questions are we going to ask with it, and what is the potential for good, is there any potential for harm, etc. And then sometimes, you know, if there is potential for commercial use, or there can also be issues around fair benefit, as to where the data was collected originally, what the original consents looked like, etc. So that's just really setting the scene for you using secondary data. And now I'm hoping that going through some of the legislative stuff, which, as I've said, is a bit complex and a bit dry, will answer some of the questions, and then we'll end off with the you sharing your data out. So we have to begin by talking about the POPIA, or the Protection of Personal Information Act, which is now in full force. It came into force in July 2021, I think. So, and it's what's known as principle-based legislation, in that it does in fact require interpretation. And there's not always agreement on that interpretation. And in the run-up to POPIA being published, there was a huge amount in the local literature, in the South African Medical Journal, as well as in the South African Journal of Science, around debates, particularly around broad and future consent, and whether or not POPIA actually allows that or not. And there was a lot of disagreement, and I think there still is some disagreement. So it's important to recognize that the legislation is it's not research focused. It's not been written in a way. The National Health Act has a whole chapter on research, and but POPIA is written for broad use of our data, however, by whoever. It's not research based, but research is mentioned in quite a few places. And it's reuse of personal information or health data constitutes further processing in the Act. And the Act also requires collection for a specific purpose. So, and further processing must be compatible with the original purpose of collection. And that's really important. And that's where all the worries around broad and future consent have come in because of this. And there needs to be transparency around further processing, and generally a data subject should be notified. But that sounds like it's all sounding awful, but actually when one unpacks it all, it isn't that bad. So the first thing to make sure to understand is that POPIA excludes de-identified information. If your data set is completely de-identified is different from anonymized. Anonymized means in one particular Excel spreadsheet, maybe you've taken all the identifiers, but somewhere else you've still got all of that information. In the eyes of POPIA, de-identification means it's gone. That link between your data set and the actual people has gone completely. And somebody who's a burglar who really wants to try and make the reconnection wouldn't be able to. So that's the standard that the Act sets for de-identifying information. And then POPIA, I'm not going to talk about exemptions, but because those require actually having to make an application to the information regulator, and we don't want to have to do that. But there's many places in the Act that talk about that you can't do something unless it's for historical, statistical, and research purposes. So in fact, the Act in many places is far more open than what one initially, may think about it. And this is really important. So every instance of processing of personal informational data, health data, has to have a legal justification. And there are only 6 to choose from. And the most important one is this last one, F. If necessary for pursuing the legitimate interest of the responsible party. So the responsible party is UCT, is the overarching responsible party, and you as the researcher are part of that idea of a responsible party. And in the latest revision of the National Health Research Ethics guidelines, which haven't been published yet, but they're in final draft, and I think they're about to be published very soon. They actually have stated they've had a legal, I'm assuming, I know there were lawyers on the drafting committee, they've had a legal interpretation that research activities are legitimate interest within academic institutions in terms of the Act. And so that is the legal justification for research. That's how it has been interpreted by the National Health Research Ethics Council. And why that's important, because it opens the door. If you're justifying your research on a legitimate interest justification, you don't have to rely on a consent justification, which doesn't mean you don't have to have consent, for clinical research, or in many, ethically you do, but it means that it opens the door for using human data without consent under a specific set of circumstances. So I think it's really important to understand that. Are you with me on this one? Okay.
Sorry, can I ask a question?
Yes.
So does this apply to not necessarily to consent health data, but to data that's collected as part of routine care? I think it was the last 2 points when you were listening.
I'm going to talk in quite a lot of detail about that.
And research activities means any research activity.
So that appears to be what's come into the National Health Research Ethics Guidelines. Yeah, that health research activity has been interpreted, obviously where there is a desire for social benefit to come out of it, as a legitimate interest.
So if tobacco companies wanted to do research into vaping and sort data from the provincial data set, it would qualify.
So, I mean, it would perhaps on a legal basis. Remember that the legal things and the ethical things do not always, and the standards are not always the same. So it may well mean that from a legal point of view, yes, they can, but from an ethical point of view, I mean, and that's why ethics committees remain so important, with this legislation. So I wanted to just talk about broad and future use consent, because this has been a really hot debate topic. And so much research involving use of secondary data often relies on broad future use consent. If the data has been originally collected as part of a research project, and then you want to use it further down the line. And so POPIA requires that data collection to be for a specific purpose, and that further processing needs to be in line with that purpose. So as I've already said, there's debates in the South African literature. Some legal scholars, particularly those coming out of the UKZN environment, have taken a very narrow interpretation of the Act, and have said that basically broad consent is not allowed. And others have argued far more broader for what they call a purposive interpretation that takes public interest into account. And in the NREC Department of Health final draft guidelines, they do allow tiered and broad consent. And I'm quoting from the new guidelines: broad consent is consent for storage and for future use for future research that is within the scope of the current research. This is permitted even if the precise topic of future research is unclear at present. So that it does require interpretation. For me, it means that if your original project involved TB and HIV, then you can use it. It doesn't mean that if the original project involved TB and HIV, you can now use the data for schizophrenia or something. That's how I would interpret it. But sometimes and there may even need to be cases around things that actually make this kind of legal instrument, more clear than what it is at the moment. We know that ASAF were drafting a code of conduct, and that is now, they're not pursuing that anymore. So that ASAF code of conduct will become like a guideline, but it isn't actually going to become an interpretation of POPIA for the research environment. And so POPIA says that the further processing of personal information is not incompatible with the purpose of collection if the information is used for historical, statistical, or research purposes, and the responsible party ensures that the future processing is carried out solely for such purposes and will not be published in an identifiable form. So POPIA does allow future processing of information. And I think the bottom line is to try to ensure that requests for future use are as specific as possible and aligned with the original purpose, and that the data is either anonymized or preferably de-identified. So from my side, so broad and future use consent is allowable under the Act, but we need to just narrow it down somewhat. It doesn't, that sort of idea that data collected for one project, that there's a pretty much a carte blanche. And it's a long time since I've sat full time on a human research, clinical trials ethics committee, but I remember those, those long consent forms where they always wanted to, just take samples and take data and store it. I think that under this Act is probably going to be problematic going forward. So I wanted to talk now about waiver of informed consent for clinical and public health data. I do believe it is still possible under POPIA as legal justification of research based on legitimate interest. And the Act says that information must be collected directly from the data subject, except as otherwise provided for, and either that you do get consent, but collection from another source would not prejudice the interest of the data subject, and compliance is not reasonably practical in the circumstances of a particular case, and that's meaning obtaining consent. So I think just to go back to the NREC 2024 guidelines, in a way they almost look like there's a little bit of a conflict, where in one place they say access to personal information for research purposes, whether directly or via third parties without consent of the participant, is not permitted. But then further down they say they do in fact allow ethics committees to provide a waiver of informed consent if it does not infringe any right of the participants and obtaining consent is impractical, and if the rights infringement is minor and is outweighed by the expected social value of the research and obtaining consent is impractical. So that's what's in the guidelines. I think they have interpreted the legislation. Maybe in a year or two's time, there might be a legal challenge to that interpretation. But for now, I feel that as soon as these guidelines are published, we can use that as meaning that we can, in fact, use research, clinical data, hospital data, clinic data for research purposes without going back to get informed consent, on the condition that there is a public benefit motivation, that it is being used for socially relevant research, and that the data will be adequately protected. So then the privacy and security things come, and requirements come in very clearly. So yeah, also this is just to, sometimes one has legislation. Obviously the National Health Act is much older legislation, but just to say that, the National Health Act did always allow research using patient data and patient files. And my interpretation, and certainly what the drafters of the new Department of Health Ethics guidelines are interpreting, is that still is the case, even under POPIA. So just in summary for this section, so use of non-research data for research, always best if you can receive the data in a de-identified form. The idea of an honest broker system where the data owner or producer contracts a trusted party, it can be in-house or external depending on capacity, to produce a de-identified data set that can be shared. That's the optimal way. So if you're wanting data, from TB clinics or whatever, that you actually have an honest broker that can provide that data set that's already de-identified. But sometimes I understand that may often not be that practical. If you access clinical data that retains identifiers, then you would need to motivate for a waiver of informed consent for the ethics committee, unless it is practical to reconsent. So ethics committees would request this in some contexts. I think it's very rare, mostly, and if you have a good justification for your research, and it's socially valuable research or clinically valuable public health value research, and you motivate for a waiver of informed consent, then I think mostly, in my experience, an ethics committee will give that. And then data security becomes very important. So you would need a data management plan that covers this in sufficient detail. And you'd need to explain, how you're going to use the research, and that there aren't other ethical things that need to be taken into consideration. So one thing that's important to note is that research that involves merging two data sets is regarded as very high risk from a POPIA legislation point of view. And if those two data sets belong to two different legal entities, and you want to merge, so you want to use data, I'm not in your field, so but you want City of Cape Town data and Western, I don't know whether that's considered too, but you want to merge two data sets, you actually under POPIA will have to get specific permission from the information regulator to do that. I think if both data sets are owned by the same entity, then you wouldn't need that permission, but it's still flagged as a particularly high risk activity, and you'd have to be really careful that you're taking all the security the security, privacy things taken very seriously. So cross-border transport is also really important. So POPIA requires that a country to which data is transferred has equivalent privacy legislation in place, and if it doesn't, then you have to have a binding contract, a legal agreement, so a data sharing agreement, which ensures that the privacy the privacy standard in whoever you're giving the data to is going to be the same as what we would require in terms of this legislation in South Africa. So it doesn't mean, and the country where is considered to not have as good a standard as us is the US. But transferring data to collaborators in the US is possible, but you would need to have a data sharing agreement where they agree. And we're talking about identifiable data, at least with some identifiers. Once you have de-identified your data completely, you are no longer subject to POPIA. Yeah?
But de-identified means no dates or obfuscated dates and no facilities and it's not just.
It does.
And then.
It means that
Yeah.
that somebody who really wanted to try and re-identify the data wouldn't be able to. So aggregated data that's been, adequately data perturbation, as they call it, that's de-identified data. Yeah. And obviously, sometimes it loses its value once you do that. So, yeah, cross-border transport has implication for use of certain things that lots of people like to use, Monkey, Google Drive, etc. And you should rather use Microsoft Online is okay for surveys, and you should store your data in UCT sort of recognized data storage facilities. And then data security is also really important. So increasingly understanding how to encrypt data, and Andre Leroux in ITCS is an expert here, and he can always help. And I can always, if you do have concerns about that, I can always help put you in touch. So there are various things about using encrypting data that, there's a whole lot. It's not an area that I have any expertise in, but there is help available if you need that. Just to say that UKZN have got this, it's a bit clunky, to be honest, but it is quite useful, a website where you can go in and look at data protection equivalent legislation throughout Africa. So if you've got partners that you're working with in wherever, Kenya, Malawi, wherever, you can actually pull up and do a comparison, which is quite useful. So just to say that this is what's known as a privacy impact, personal information impact assessment. And this was the one that was in the original ASIF code, which is now not going to happen, but it is going to be, these questions will be included in UCT's data management plans going forward. And these are all what you could consider red flag questions. So they are all instances where you need to take particular care under PAPIA that you are actually protecting and managing and storing and sharing your data according to, in a careful and responsible way. So I'm not going to go into them in any detail. I can share the slides afterwards. And yeah, I've already said this, but just to say that there is actually a section in PAPIA, section 57, that would require you to apply if you wanted to merge data sets that were in different. You would have to apply for permission to the information regulator if you want to merge two data sets via identifiers that are owned by two different entities. So that's, I am getting to the end. How are we doing for time? Yeah, okay. So that's the legal side. I hope I just didn't make you more confused. But it is quite complex, but in the end I feel that, especially with the new NREC guidelines, they've obviously really thought about what is in the Act, and I think there's a whole section on informed consent, which I think is really excellent. So, they really are providing the support that researchers will need going forward. So, briefly, I'm getting to the end now. That obviously we know data sharing. So this is going the other way around. Not you using other people's data, but you wanting to share your data. And so we know it's becoming an ethical imperative. Open science, promotion of the common good. There's so many reasons why you would want to share your data. And there are a lot of hurdles, and I think we've already discussed now quite a lot of these. So we've discussed the complex regulatory framework that's involved. We haven't talked, and I'm not going to, but about equity and social justice issues. around, and that was the Cape Town statement tackled a lot of that, around the pressure that's often put on researchers and LMICs to share data and make it open very quickly, where they don't have their, an embargo period where they can actually do the secondary analyses and the various things that are required, and then you have people that had nothing to do with the original project and have all the resources in the world sitting in high-income countries that then will come and want to reanalyze that data set, and also may not have, the insight into the communities and to the various factors on the ground in the local environment. So there are a lot of issues there. Community factors and participant factors I haven't just talked about community factors, but participant factors we've spoken about. So it's a complex regulatory. There are a lot of hurdles. Just talking a bit about community, I think that often around these things there isn't, and in some projects. Not all, I'm sure, but just from some of the stuff that I've seen from many years of sitting on ethics committees, is that we don't always do community engagement as well as we could do, and particularly around things like data sharing and that. And so the questions are, how can we do this better? I had somebody approach me from your faculty just couple of weeks ago about possibly setting up a sort of a community engagement faculty forum to try and do this, and we've talked about possibly developing some specific training for young researchers around community engagement. So I think being able to speak to stakeholders about their understanding and expectations around data transfer is really important. So yeah, data management plans going to become increasingly important, that they're built in to projects. And I think I'll just skip that slide. Yeah, so this is my last slide. So key take-home messages: de-identify wherever possible. POPIA does not apply to adequately de-identified data. And oopsie, sorry, slide. No, one more. So, and as I've said, de-identified means no possibility of re-identification. Collect only what is personal information you really need. So that's another POPIA principle that I haven't spoken about, but it is the principle of minimalization. Don't go and ask for a whole lot of, what are your religious beliefs and, what's your political affiliation and all of that kind of stuff, because maybe one day down the line it might be useful. Don't do that. Rather just, get the information that you actually need. So be transparent, make sure your participants know what you're going to do with the information, who you're going to share it with. Keep information safe, so data security as important as data privacy, and identifiable data cannot be transferred across borders unless the recipient country has data protection laws equivalent to POPIA, or you have a legally binding DSA in place. So that's it from me. Thank you very much.
Thank you so much, Lyn. Great work. I have lots of things to think about. Well, I don't know if there's questions from the floor here or points of discussion. I also just want to see online if I can see if there's any comments or questions in the chat. Let me just open this out so we can see. Anybody's got any raised hands? Any discussion? Yeah, go for it, Leslie.
Thanks, Lyn. It was really helpful. Just a comment, I think when you posit the initial difference between public health ethics and traditional ethics, you use the concept of rights in a very individual way. And rights also exist in a very non-individual way. So the right to enjoy the benefits of scientific progress is a right that can't be realized person by person.
Sure.
So it sits on both sides. I think the examples of what would be a plausible linked use. So I'm just thinking, for example, we're doing a study in KwaZulu-Natal. Let's say we were doing a study of children exposed to pesticides in the sugar farms. And we, planned our study, we got consent for what we wanted to examine. And then the fire at Cornubia pesticide ball erupted in 2021, and we realized, oh, we should actually look for this other thing. So it's a different toxin we're looking at. So that I understand would be the plausible common, the same rationale. But if you then took, used the bloods for genetic analysis for effects of toxic chemicals is one thing, but if we then use that for, I don't know, looking at things which might be relevant to pharmacometabolism, that would be like too far.
I would think so. So it's going to require, a bit of a reasonable person standard to try and interpret these things, and I guess ethics committees will play a role in this. But yeah, I think that would probably be, and I'm sure it's going to happen, or because especially with sponsored research, this is going to be a big change for many of the clinical trials, the sponsored clinical trials that I've seen in the past, that do feel that they can use samples and data for a very broad range of things afterwards, and that's often included in a consent documentation. But I think the idea now is that you shouldn't be putting that in, that even if there is a signature that says you can use my data, that isn't actually valid under this legislation.
So is this already all in effect?
Yeah, it came in July 2021.
Thanks, Lynn. That was lovely. My name is Zeki. So my question is not specifically to the use of secondary data, but rather the interpretation of data. I've come across now, so I've had to give a lecture on decolonizing public health, and I came across some papers where I really find as a source of discomfort that when people are working, particularly with international partners, that there's almost like a pressure to label their findings. And so for instance, there was a study that was done in Lesotho, Swaziland, the Western Cape, and I can't remember which other country. It was looking at pain in HIV positive patients. Yeah. And my pain positive patients. And the issue there was that, so for instance, if you're looking at the study that was done here in the Western Cape, there were about 170 participants, and but the interpretation was around tribalism or cultural construct, where it's, there's Amaxhosa, and when you're looking at Amaxhosa, everybody who is Xhosa speaking is, included in that statement. As one is looking at a particular setting, the participants are limited, and it also is one is looking at the context. The minute you talk about HIV, one needs to be careful around how that is presented, because you can stigmatize a whole group of people. And so I think that this is something that we need to be, looking into going forward. Because if we're going to be talking about, social justice and issues of transformation, we also need to make sure that we don't harm communities in the way we interpret the information that we've collected.
No, I agree completely. I think, I don't know if you've had a look at the Cape Town statement, but those were some of the specific points that were actually raised about, about issues where you have too much dominant influence coming from people that are not understanding the context in the way that they need to. Long ago I did a little bit of working in philosophy around social justice and using fetal alcohol syndrome research as a, and there a huge amount of research has been done led by investigators, particularly from the US. And I think a lot of those publications were published without the sensitivity. Entire communities, were stigmatized around some of the stuff that was published. That's in my view. So,
Question. Thanks so much. It was really interesting. I wanted to find out how research ethics committees were being capacitated to take on some of this, because I guess a lot they've got tremendous power in saying that the informed consent falls away in this instance. Are they taking on some liability or responsibility in that space? Is there any threat? Because I tell you why. We put in an ethics application. I got such a mealy-mouthed response from the ethics committee when we had an issue around linkage and privacy. Kind of to the essence of it was, well, we don't really want to say if it's POPIA compliant, but we're happy to grant ethics permission if it's POPIA compliant and meets health research guidelines. It was really wishy-washy, and we actually flagged for them this issue around linkage and privacy. And I'm trying to understand that response. Are they feeling the heat and like the liability is being passed on to them, that because they've got this power that they're unwilling to take it because POPIA could send them to jail or something like that? It's just a very strange dynamic.
I think in a way you've hit the nail on the head in a way. If you look at the history of this, when the ASAP were first drafting this code of conduct, the initial versions that came out placed the gatekeeper responsibility for POPIA on ethics committees. Yeah. And there was an absolute uproar from ethics committees across the country to say we've got enough of a burden and we cannot take on this responsibility to be gatekeepers for POPIA, and that it has to be pushed, kind of pushed back either to the responsible party, which is the institution, and that's a bit, because institutions, I think even ours, well, obviously ours, because I'm supposed to be leading the POPIA research project, and there's just so little capacity to put in all the things. We're getting there slowly, but to support researchers. So there was a huge amount of pushback around that. I think where the answer lies is in the new EMRIC guidelines, as soon as because they have drafted those guidelines with legal consultation and to be POPIA compliant. So, and they are very readable and very accessible. So, so that would be where I think you would be able to know that your project actually is, if you're abiding by those ethics standards and those guidelines, that the project is almost certainly going to be POPIA compliant. But it's complex legislation. It's taking me a long time to get my head around it, and it has these 8 things for 8 sort of requirements, which I didn't speak about today. But I think mostly ethical health researchers are actually, in my view, compliant. There's a few little things, the extra things like this merging of databases, which is a specific thing. But on the whole, I think if one carries on pretty much the way we've been doing things, on the whole, I think most health researchers are okay. Where the problem probably lies is in other places that are not doing health research, but other social where the frameworks for research are far more fluid, and there may not be a level of awareness that there is in this faculty. You wanted to ask something?
Yeah, possibly along the same lines. I think you brought up 2 things. One is sort of what qualifies as being de-identified data, and the other is merging of data sets. And I think that's actually something that we do quite often, actually, in terms of either merging kind of routinely collected public health data, or even sort of enhancing your research data with, for example, the clinical information in sort of laboratory data sets.
Yeah.
So where do we, sort of who do you use that? Is that sort of a balance in between sort of the public health good of the work being done relative to sort of the legal mandates to be popular? I'm just trying to understand, because I think that is actually not an uncommon practice, I think, in the work that we do, and it's quite important.
So I would imagine that a lot of the data sets that you merge probably actually, if you looked at under whose auspices, they're probably under the Western Cape provincial government, so that requirement that if they're completely owned from different entities, you've got to go to the information regulator. In most cases would fall away. And I think the public health, throughout the legislation, if you actually read the act, that this public benefit thing comes through all the time. So, to me, the red flags would be particularly around children data. That under POPIA, you've got to be very careful about how you handle children's data. So merging data sets with children involved would probably require actually a formal application to the information regulator. But that's the kind of thing where you would need to get help from somebody at UCT. You can always come via the Office of Research Integrity. We often don't have all the answers, but we can at least point you to the people that can help with those sorts of highly, more sensitive, high-risk kind of data processing activities. But if there's a strong public benefit, then it's probably, and you're taking care, then it's ethical and probably legal as well. So.
We have one comment online. So finish your question, Alex.
Just a quick follow-up in terms of sort of rules or guidelines around what would make data identifiable. So I know, for example, in the US, sometimes if you're reporting HIV cases in a county with 3 within 5 cases, then that, you can't present, you actually present aggregate data. Are there sort of guidelines around sort of,
I'm sure there probably are. I can't, I think there probably would be. I mean, qualitative data is also, it's a lot of qualitative research done, and often qualitative studies embedded in, in larger studies. And so making qualitative data not identifiable can be very, even if you take the names and dates of birth, there can still be many circumstances where people would say, oh yes, I know who that was. So, yeah.
We have a question online from Marianne. Go for it, Marianne.
Thanks, Lyn. Fantastic and very useful presentation. So, so really appreciate that. I have a question around something that we quite often face, and my role is partly as reviewing requests to the Provincial Health Data Centre for access to data. So kind of making sure that we have adequate governance in process and processes in place for that. And what we have quite frequently is requests from clinicians. It's often usually registrars who are doing their MED, who are clinicians who have access to a particular set of data for clinical reasons. So as part of their clinical care practice, they have access to be able to look up all the lab results on all patients that they've seen, or all patients that are part of their program for clinical review processes. And they now want similar access for research processes. And often that involves some degree of identifiability, because they've identified this list of patients who've undergone, let's say, a particular procedure, and they want to know their outcomes a year later. And it's often quite difficult to decide in those circumstances, because obviously for the clinical reasons, those people had access to the identified data, but for the research, it should ideally be de-identified. What is your guidance there on what is appropriate and allowable especially for people where, yes, they do have access to a subset of those patients for their direct clinical care, but often the patients are kind of under their jurisdiction, but they may not have actually personally seen that patient and said, yes, can I access this data?
So I think, if it's not within a formal research project that's been written up as a proposal and gone to, so even, and I can understand that if it's an MMed, it is probably going to be within your field and patients that you may or may not have seen at some point. So I do think this kind of clinical audit sort of thing is acceptable, and I can't, from my understanding of PI, I don't see any reason why, why there's a barrier to it, but that privileged access can only happen under a formal research project that's gone to an ethics committee and had motivated for a waiver of informed consent, which has been given, and then that would allow the access. That would be my guidance on it.
Thanks, that's very helpful.
Yeah.
Thanks, Marianne. There's one other comment here, Lyn. How does this legislation impact the ability for researchers to work on data linkages for health and using data across jurisdictions? Or is this just too much to try to link data across jurisdictions?
Researchers to work on. I mean, I think, we have talked about that. So it's regarded as high risk processing within the legislation, and you would have to be really careful that you're doing it in a way that's taking care. And the 8 criteria in the Act in terms of minimization and data security and all of that, I can't remember, all of them have been taken care of. And again, if the Section 57 of the Act requires, if the data sets are from completely different jurisdictions, that you would then have to make an application for authorization with the POPIA at Information Regulator Office. So, and I would say before doing that, it would be a good idea to discuss it with. So what we're trying to do is establish an area of POPIA expertise within the Research Contracts Office, because they have lawyers there, and that would become the first port of call where you have these, your project involves linkages, and they would then have a look, and if necessary. Currently, UCT has got contracted legal experts that have provided reviews on a case-by-case basis. So, would be able to provide support and help around that.
That makes sense.
Yeah.
I think with that, our time is up. Really huge thank you, Lyn. This has been incredibly valuable. Thank you so much. Thank you for all the questions. And have a good rest of the afternoon, everyone. Thanks for those online. We had a big audience online today. Thanks so much.
Thanks for having me. Thanks, everyone.
Thank you all.
Then can we use the NREG regulations before they come?